the patient with corneal endothelial dystrophy. This patient, as you can see in 3D, has a nice deep chamber, so that's good. But what do we want to do to protect that endothelium during the procedure? So let's talk about that. So there's our side port opening. And then there's our 2.4 millimeter keratome. And now a little bit of lidocaine. And viscoat, lots of it. I'm filling the chamber, really, with the viscoat. Great protector of the endothelium. And now we'll open the center of the anterior capsule. There was some stria there, but it may just have been because one portion of that needle wasn't so sharp. We'll pay attention as we do the rhexis. So I'm going to center the eye. So what we're going to want to do here is divide the nucleus into small pieces that can be removed almost in situ, meaning not up in the anterior chamber near the endothelium. And of course, as always, we want to minimize the use of ultrasound, especially ultrasound near the cornea. The zonules seem fine in that go around with the capsular rhexis. And now we'll do hydrodissection, the flat 23 gauge needle, and then viscodissection. So we'll test our infusion capacity. It's good. And in we go. So I'm going to clear some of the viscoat from the top of the lens. And I got to center this microscope. That patient moved a little bit, so I reached the end of my travel. There we go again. What, the cornea? You can feel water on your eye, nice and still. Good. So that ultrasound is nowhere near the endothelium. What, the cornea? So the ultrasound used during sculpting is generally less traumatic to the endothelium because it's done at a distance with the port facing away from the endothelium, the ultrasonic pressure wave going away from the endothelium. So I'm dividing this lens into 6 pieces, quadrant removal. And now we'll see how much we can aspirate them rather than use ultrasound. And that little motion, moving around, finding a thick area that will occlude the port, is a very nice way to reduce ultrasound by doing essentially phacoaspiration. What, the cornea? Now see that piece that's just sitting there in the middle? Why is it sitting there? Because it's in viscoat. So fluid flow doesn't affect it. So I'm going to take it now from below. So it's good to have the viscoat staying there, and it'll stay there if you're not working near it. So here we go for our last segment here. That was right in the middle of the nucleus, that piece. Yet it's still aspirated just because we waited long enough for it to deform and enter. A little piece over here. So now we're ready to do INA. That was a little piece of epinucleus there, removed it. Now, if you look again at the corneal dome, you can see, let me zoom in and focus on that for you. Little microscopic lens fragments sitting there. Again, why are they not washing around? Because we've got viscoat there. It's really possible to lose virtually no endothelial cells, at least from the central cornea. Around your primary incision, research has shown that you lose about 160 microns of endothelial cells. And I think it may be less than that now, because if your incision isn't leaking much during the procedure, then you don't have a torrent of fluid running past your endothelium. So that's probably even better. Okay, so now we're ready to put in some Provisc here. And then the IOL. And again, you can see these little particles, they're still on the endothelium. So here goes our IOL into the capsular sac. So the endothelial cell loss should be really, in an eye like this, at 1 year, when they're stabilized and you can count them, less than 1%. And I've got a large series of them that shows that it is. Okay, so now we're going to remove OVD from behind the IOL and a little from the plane of the capsule, but I'm leaving the rest because I'm going to gently irrigate that out. I am not going to try to take viscoat off of the endothelium. You can see strands of it there washing around, a little bit of flow. I will try to irrigate the angle gently, as we'll see now. But not as aggressively as normal. Okay, so when you leave a little more OVD than you usually would leave, there's a little piece of something there, I'll aspirate it. Check the IOP in an hour. But I think that's preferable to checking IOP and using medication to lower IOP than rinsing OVD off the endothelium and damaging, losing some cells. So that's it. The low cell count corneal endothelial dystrophy patient and what we try to do to preserve endothelium.